Okay, I guess we will start. Good evening, everyone. Respected Dr. Vishal sir, members of the IADPE, and dear doctors. So, we welcome you back for another episode of Learn from Our Master series organized by IADPE, and it's always a pleasure to be here. So, for those who are attending our webinars for the first time today, we would like to give a little bit of introduction. We are the International Association for Dental Practice Excellence, a dental platform in which we believe quality education always ensure predictable outcomes for dentists of all disciplines and abilities. Our organization is established based on the fact that the dentistry is complex and requires ongoing learning experience. So we conduct various webinars and workshops to enhance the skills of dental professional and guide their dental journey. So without further ado, let us start our series episode in which our topic of discussion is access is success. Let's open the door to RCT correctly given by Dr. Vishal sir. To speak about sir, Dr. Vishal Gandhi completed his BDS in GDC Gujarat and achieved diplomat in microendodontics from University of Salerno, Italy. He is doing his own practice in Ahmedabad since 10 years and work as a consultant at more than 30 dental clinics. He was the KOL for the Colteen and Dentsply and now is currently working as a KOL for Oricam, 18th and Zoomax internationally. He is the first Indian gold member of esteemed Facebook group of 3D cleaning project and has done various publications in the field of microendodontics. He conducts various workshops in IDA branches and takes one-on-one endodontic session and a ride at his clinic. So without wasting more time, I would like to invite Dr. Vishal sir for today's discussion. Sir, please.
First of all, thank you, Dr. Shanu and Dr. And the team IADPE for to having me here. I'm audible and visible. Everything is okay, Shanu?
Yes, sir. Yes, sir. Please
Okay.
continue.
Yeah. Okay. Let me share my screen first. Okay. Now this is okay.
Yes, sir. Yes, sir. If
Okay.
anything is
Okay.
there, I will let you know, sir.
Perfect. Perfect. Thank you. So first of all, welcome everyone to this Monday evening uh, webinar, and our today's topic is access is success. And let's open the door of RCT in correct manner, right? So, if you ask me what I have seen, especially where there is a mishap in any case, or maybe there is some kind of issues are there in any case, the first thing what I have noticed in last past 10 years. Unfortunately, the previous clinician has done some kind of mistakes, specifically in RCO access cavity depression. So, I always say this. This is the door which you should open very correctly. So, the next step, for an example, your glide path, your shaping, we call it biomechanical preparation, right? Your irrigation, even your obturation will be corrected automatically if you open the door of the tooth, what we call it root canal access cavity depression, right? So let me start our session with the definition. What Dr. Stephen Cohen said. He said it generally refers to the part of the preparation from the occlusal table, from the top of the tooth to the root canal orifices, right? So it's very easy to understand, but this very easy to understand thing, most of the times, clinician done a very huge mistakes, and that is the reason many times you will see that your file is getting break even though you have used or you have using you are using the first file from the packet itself, the newest file, but still this thing will happen. So what are the objectives of the RCO access cavity preparation? And when you see the objective of the root canal, right, or the endodontic treatment, the first thing you will notice that the base of that pyramid, I mean main three or the four steps, what we calling RCO access cavity preparation, cleaning and shaping, and the last one is the filling. The base of that pyramid is always your RCO access cavity preparation. And what Dr. Walton said, objectives for proper coronal access forms the foundation of the pyramid of endodontic treatment. And what are the objectives? Straight line access. We always hear this. We need straight line access. We need straight line access. You know what? The criteria for straight line access in the past, in Gutman era, we were doing like from the orifice to the exit, I mean the foramina, ideally you should have a straight line access, but the criteria has changed. You should have a straight line access to the first curve of the canal. And why we are doing this? Because we have a newer nitide materials, I mean newer and a good nitide files, which can help us to go inside that root canal space, right? It improved the instrument control. Many times what I have seen, clinicians always make mistakes in taking working length. If you are making a proper coronal access, your working length will be somewhere constant compared to un or improper RCU access cavity preparation. Many times you have seen that, sir, my GP con, my Gataparka con is not reaching to the last terminus. You know why this happens? Because you have not flared the RCO, I mean the RCO access cavity preparation. And it will help you to decrease your procedure errors, right? So when we say root canal opening access cavity preparation, right? RCO access cavity preparation. The must and the most important, the prior thing we always need, that is the pre-operative radiograph. And that radiograph will help us to get to understand what is the morphology of the tooth. If you see on the screen right now, are you able to see how many, are you able to appreciate that how many roots are there or maybe how many canals are there, right? So, this type of scenario happens every day. This is the left maxillary, second molar, right? So, I will come on to this part later on also. What is the anatomy of the root canal system? What is the number and the length of the canals? And the most important, especially Dr. Shanuv has done a very good case, and yesterday he posted in social media, and I saw the case. It was very, very beautiful. It was a case of a multi-canal. For an example, a split, whether in which that was a case of one and the three canal. I mean, the one canal, main trunk of the canal, getting divided into first two and the third canal. So it was a one, three type of anatomy. So especially the branching of the canal system, position and depth of the pulp chamber. Your pre-operative X-ray will tell you how depth you have to achieve for that specific tooth, position of the apical foramen, and the most important, are there any calcification or calcified parts are there in that particular tooth, right? So, what are the instruments which I prefer? See, I am not here to advertise any company or I am not here to promote any company. From the next 30 minutes, what I will speak, that will be all about how I use and what I use in my practice, right? So, what are the burrs specifically I use for this RCO access cavity preparation? The most important thing which we always neglect or forget, that is the perio probe. Whenever you even wish, even think to do the RCO access cavity preparation, you should have that perio probe. And this perio probe will help you to stop doing perforation, especially in the calcified cases, especially in the geriatric patient, and especially in the some kind of different chambered tooth, right? So the other burr which I specifically use and my most favorite, we call it Endo Z. You have two options. One is from Dentsply and other is from Trihawk company, which I use regularly. That is the Amazilia burr. It comes same, but in a greater, I mean the longer, it will come in a much longer length. So your normal Endo Z is 21 mm, but that Amazilia is 25 mm. And I will today I have planned a recorded RCO demonstration also for you guys, right? So I will show you each and everything, even which type of other burrs I use. For an example, straight Fisher 11, SF11, taper Fisher 11, even the round burr, right? So I will show you that everything in the live demonstration. Okay, the most important thing which as a clinician you should have, that is the good front surface mirror. You know, the Relax FS Ultra is very good. The other option you can have that Zerk mirror, right? And whenever you are going more posteriorly, for an example, if you are doing a RCO in number four tooth, I mean 3-4 or the 4-4, first premolar, right? You can use the size 5 mirror. But if you are doing RCO access cavity depression in upper 7 or the lower 7, my suggestion would be to have a smaller size of mirror. For an example, size 3. This will help you to adjust your aorta in between. And this is the reason you will have a good vision. Once you have a good vision, you can play with your aorta. Because most of the time, what I have seen, a clinician is going more on the measure side because he is or she is not actually seeing what he or she is doing and eventually end up with a large removal of the dentine in the pericervical area, right? So this thing you should keep in mind. And when you are thinking about the RCO, excess cavity preparation, keep this thing in mind. 5 mm is the rule. Now, what is the 5 mm, right? So in a normal anatomical tooth, when there is no attrition of the tooth, you can go first 5 mm. And how you will get that, you just need to shrink your half a burr. For an example, if you are using the standard burr from the money, right? So the working area of that burr is 10 mm. So you should go only 5 mm first. This 5 mm will help you to go near to the roof of that chamber. And the second thing you should remember, that is the 7 mm rule. So 7 mm is your deepest point. Always make sure you will not go beyond 7 mm in any condition, especially when there is a normal anatomical tooth. Okay, this 5 mm becomes the deepest point or the maximum limit when you have a geriatric patient, when you have a attended tooth, when you have some kind of anatomical disturbances, right? So this is how you can prevent your initial depth. So always remember, only half of the burr you will get down with your, like for an example, SF11, or when you want to do the perforation, when you want to have a drop fill in the chamber, you can use your TF11, right? Before we start, before we go more clinically, please keep this in mind. Don't use your normal three-way syringe, especially when you are doing your RCO access cavity preparation. It is always about the Stropco. If you are not knowing Stropco, my suggestion would be just do a Google once and have some information regarding what is the Stropco irrigator. This will reduce the compressor pressure from your chair, and you can literally remove or dislodge the debris which is getting created when you are using your aerotor. Otherwise, I have encountered 2 or 3 cases from the other clinician, and they have referred case to me, which in which patient was having emphysema. You know, this is the very sad thing. Ideally, please don't use the three-way syringe, right? So let's go something more into clinically. So what are the laws of the anatomy of the pulse chamber floor? This is given by Krasner and Ranko. For an example, if you are not getting any orifice in that particular tooth, my suggestion would be to be in the center, especially in the molar. Why? Because law of centrality says the floor of the pulp chamber is always located in the center of the tooth at the level of the CJ, right? If you are not getting that, like which depth I should go in. The law of color change. The floor of the pulp chamber is always a darker than the surrounding dentin wall. So law of color change will help you, right? You have to be in center. And if you are getting, for an example, mesiobuccal canal, always have a good vision with a normal or with a good relax FS ultra mirror or zinc mirror. And try to see where you are getting mesiobuccal and take a sharp DJ16 probe and scratch on the same line from mesial to distal, or sorry, from buccal to lingual or lingual to buccal, and correspondingly, you will get the other canal, and respectively, you will get the other canal, right? So this is law of symmetry 1 and law of symmetry 2. So for an example, in lower molars, if you are getting a distal canal in some kind of angle, not in the center, you need to understand that there will be second distal canal for sure. Now, unfortunately, this Krasner and Renko's law only apply in lower 6 and D7, particularly tooth lower 6 and D7. So what about the other teeth? Unfortunately, this is how you should learn, and this is the practical thing which I will show you. So one more thing, radix cases, whenever you see an extra root spatially attached to the distal root in the lower molar, you need to understand that that orifice you will get in some kind of angle, and you will have to you will have to modify your access more if the radix is on the lingual side, that it is become radix entomolaris, then you have to expand your RCO more onto the lingual side, and same for the radix paramolaris on the buccal side, right? So keep this thing in mind very well. Yes. So this was the concept, right? Or what are the concept to have a flare in the RCO. You know, the Gutman concept what was what you are seeing on the screen, the slide C or maybe the image C. The first concept was to have a wide flaring, especially on the mesial side for your lower molars, and why he suggested this, because you will have a straight line access to the foramen. You know, but the concept has changed, and now once we are having a good nighttime material, once we are having some kind of flexibility in the rotary files, we can stay in the B. But what about A? If you are a pro, if you have a good magnification with you, if you are very pro user of your magnification microscope, my suggestion would be you can stay between A and B, but I never recommend the design A for your RCO access cavity preparation. Why? Because you will leave behind so many pulp tissues here, especially here. Here, see the pulp tissue is most of the completely removed. Here, you can remove with the ultrasonic, but this will trouble you more. So always keep this in mind. RCO access cavity preparation flaring also depends on what kind of root pattern, what kind of canal pattern you have. So, for an example, if you have a acute curvature in the distal canal like this, so, what will be your access cavity design if I ask you? Number A, I mean the side A or side B. You know, when you do the side B, you need to remember that you need to reach this portion here, and there is a high chance you will make a ledge. So, if you ask me, Vishal, what is the design of the RCO access cavity preparation? My answer is always show me the pre-op IOPR, right? So in this particular case, I will go more on the mesial side, but don't cross the 3 mm limit of the mesial marginal reach. And once you flare this, it's very easy thing to reach here if you pre-curve your file. So I have seen clinician, they go with a shape, but this is the 2024 era. Please don't go with a blind shape of your root canal access cavity preparation. It's always dependent, or it is always subjectively what is your root pattern, what is your canal pattern, right? So when you are doing some kind of minimally invasive access cavity preparation, you are leaving behind this much of the pulp tissue, and this can be the potential source for the reinfection in the progression, I mean the in the future, right? So if you ask me, my suggestion is always in the B or C, but don't go very haphazardly, don't go very aggressively and remove everything. No, please don't do A also, right? So if you have this kind of cases, if I ask you what kind of excess cavity depression you will do, you can have another option, especially when you see a MO carries, major occlusal caries. in molar, especially in the upper and the lower six and the seven. So I do this very regularly, and we call it caries driven endodontic access cavity preparation. And what is this? So in general, what we have been taught that you will flare, you will remove whole tooth, I mean whole roof, and you will remove all of the tissues in the chamber. Okay, but you can have some kind of slanting also, and you can have this kind of excess also. This is the soffit. You know what? Soffit is a responsible to have 30 plus 33 to be precisely strength of your tooth. Ask yourself, do you need crown after this? Right? So, your excess cavity design always determines that what kind of prosthesis also you will give. I have seen clinician blindly putting on the crown once they do the root canal treatment. This is very wrong, dear friends. Once you can be conservative, if you can save the soffit, I will show you some of the articles later on that it is decrease the tooth strength decreases only 9%. So it's almost negligible, what we can say, right? So what is the soffit? Can you see the line, the dentine between this line, the dotted and this line? This is the soffit. So, if you can have if you have a good experience, if you have a good magnification, you can save this pulp on and the dentin about that pulp on. I'm not saying to save, but you can be very precise. And now your ultrasonic will go inside, and this pulp on and the pulp tissue you will get it clean, right? So what are the superstition and what are the fact-based understanding when you are doing some kind of root canal opening access cavity preparation? So our superstition was complete removal of the roof. But right now, once we have a good material, a good ultrasonic tips, and a magnification, you can save this portion also, because this will help your tooth to have more 33% strength, right? Complete removal of the roof allows complete pulp removal, especially of pulp on tissue. This is very right, and at the same time, not right too. Why I'm saying this? Because if you have a good ultrasonic, you can remove this. But my suggestion would be if you're using Endo Z or MSZilla kind of burr, you can just use that burr in this direction, in this portion, and we can remove this pulp on also, right? Complete roof removal is required for safe straight line access. As I told you, we have a good nighttime material right now with us. So don't worry about this. And the most important, just put a crown on the tooth after endo to make the tooth strong. Most of the denting is expendable. The roof wall interface, the fact is the roof wall interface likely provides natural strength and stiffness to the tooth. And this is the reason I am not in a big favor of crown blindly, right? So let's discuss something about the anterior axis. As a clinician, if you ask me, or like if you ask me what is the most traumatic thing we are doing in our whole body, my answer would be an anterior cingulum axis. We have been taught about this cingulum axis, do cingulum axis, but when you are not able to see what you are doing in that buccolingual or buccopalatal plane, many of times you are going this, you are reaching to this level. And actually, if I ask you what is the most important or most strong area of anterior tooth, everyone will say me Vishal cingulum. You all are right. And what you are doing in this kind of access? So, friends, time has come because in 1999, Dr. Moger, Dr. Alexander said this. What is the ideal access, especially in the mandibular incisor or anterior incisors? I mean, the anterior tooth, always the incisor access. Because many of the times, because what studies are saying that 50% of the lower anteriors have two canals. When they have two canals, you need to access both of the canals. If you are doing from the cingulum side, the first canal for sure you are getting is always, always, and always the buccal canal. So if you are not removing the dentinal triangle which is there on the cingulum portion, you are actually missing the lingual canal. And this is the biggest issue. Sir, I am not getting the second canal in lower anterior. But if you go down like this, let's see the case. So this is the pre-op, and what I have done. Can you see this thing? Can you see how I have approached? You all remember now, your RCO looks like something over here, a black portion. Let me do something drawing for you if I can. Yeah, your RCO looks like this. Your RCO somewhere look like this, and see my RCO. It looks like this, right? It looks like this. So I believe, not I, because of the studies and because of the great paper of Dr. Mogar, you always go incisively. And this is the thing, you will get your two canals very easily. And I do the same. I do the same in, yeah, wait a second. I think I will remove this. Uh, yes, that's all done. Okay. And yes, I will do same for the upper anterior also, and which kind of specific burrs or tips you can use if you want to buy or if you want to have. This is the EG5 burr or the tip which comes from the SS White. Other is Meisinger burrs, right? Which you can have a very small, and friends, don't get me wrong. This is not the microscopic access, right? This is not the microscopic access. This is the routine access. We call it a slit access, and it shows, or it will look like this, right? So this is the slit. You should understand, and this is the incisal access. Especially when you have an upper anterior traumatic trauma case and canal is totally calcified. There is a lesion or there is an issue. Patient is having pain, for an example, and I have seen so many clinicians going cingulum access, going with the cingulum access. But if you are going with the cingulum access, you are actually not hitting the center of this tooth. And what the law of centrality says, the canal is always in the center of the tooth, especially in the single rooted tooth, right? So I always prefer the incisor. Now, someone will ask me, sir, what about the incisor edge if you are breaking it? Tell me how much minute you will take, right? And what are the advantages you are getting when you are actually using this incisal access? You are saving the most important, most precious pericervical dentin for this reason when you are doing incisal access, right? So this is how I do, right? Let's discuss something about the premolar access. I have seen clinician, they are always go with the and center in the lower premolar, oval in the upper maxillary premolar. But dear friends, when you see a split or when you see a two canal in lower premolars, that you can have an idea from the pre-op X-ray, you should extend your RCO access cavity preparation like this. Please extend your RCO cavity preparation till the buccal cusp tip. Once you have the buccal cusp tip, it's very easy to reach this lingual canal. Because as I said, from tooth number 1 to 5, in lower anteriors to lower premolars, even Stephen Cohen sir is doing, the first canal he should get or he will get is always the buccal canal. So it's always about the lingual canal if you have not extended the access preparation, right? So you need to understand the extension of the RCO access cavity preparation. So if you are having a single canal, yes, you are okay to go with the central, I mean, single round in the center, and you can proceed with the next step. That is your glide path and the hypopath and everything. But if you are having a split, right? If you are having a fast break in the pre-op IOPR, you need to extend your access cavity more buccally, like I said. So if you ask me, Vishal, you have shown us so many access types and you have shown us so many varieties. But what you prefer? Please tell us, because we are here to know that and to learn that. Yes. So I do. Let me tell you very honestly. I do this ninja access. Sometimes I do truss access also. Sometimes I do traditional access also. But friends, I never recommend to do any of the ninja, any of the trust, or any of the more of the like more aggressively traditional access. Why I'm saying this? Let's see a good article first. Okay. So like article, it's all about present status and future directions, minimally endodontic access cavities, right? So this is the time always, and everyone wants to be more conservative. but they forget that you need some kind of magnification also. So what kind of excess varieties we have? We have more than 38 varieties right now in our endodontic world. But what I recommend, I will come on to that part after 2 3 slides. So you have this ultra conservative endodontic access cavity reparation. We call it Ninja. You call it Trust. You just launch a laser guided missile, and your TF or your SF11 bug will straight away fall on that orifice, right? But please, 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 if you do not have magnification, please don't go blindly after Instagram. Please don't go blindly after Facebook, and don't attempt even this, because you are not knowing that what you are leaving behind. Though you have used a good bioceramic sealer, a good calcium silicate base sealer, still your case will get failed, and you will keep on wondering. You will keep on thinking, why? Because I have used everything, every good material. I have used every good technique. I have spent proper time with the irrigation, but why this thing happened? Because you have left behind so many pulp tissues. Caries driven endodontic excess cavity preparation. If you have a good magnification, you can use this. The traditional access cavity preparation, conservative access cavity preparation with the divergent walls, and this is how I prefer this sometimes. So this is the axial view, and this is the sagittal view of the different access cavity preparation. This is the traditional access cavity preparation. My suggestion would be go with the first option. Though they have saying traditional access cavity preparation, it is very minimal for our tooth when you are doing this kind of access. But don't do the ninja access, don't do the conservative access DFD design, because we are doing something for our patient, and we are not doing something for our Instagram to increase our followers, right? Eventually, if that patient is become your headache, don't ask me or don't follow me, right? That Vishal is like doing this. So okay, wait a second. I will go for the next slide. Yeah, okay. So this is the Rudder's data, Cliff Rudder's data, how much tissues you are leaving behind when you are doing this type of different devices, right? Yes, wait a second. Yeah, okay. So this is the factor influencing the 3D disinfection, the ninja access, the orifice detected, that is we call the trust access, the complete access, right? And if you ask me now, this is my access cavity preparation, and I named it as small as practical, the SF axis. Why I do this? So we have a good mirror. When you can be a conservative, you can just have a little bit of flare. Once you have a flare, your file will go very easily, right? And it will not have any obstruction, especially on the coronal part, in the chamber part, right? So this is how I do. And if you ask me, Vishal, what kind of shape you are doing? If you see, this is the lower second molar, and if you see, I have removed this part more compared to this or compared to this. And why I have done this? Because this canal was curved. I mean, this root was curved. Can you see this? I have removed something more on this side, on this side. Why? Because if this canal is curved, why if and we all know that we are getting entry from the opposite side. For an example, if you want to go in the mesolingual canal, you take the entry from the distobuccal canal. Am I very clear? Wait a second. Mesolingual distobuccal. Yes. So if you are going from the opposite side, the cross side, right? So you just need to understand this is how I do this as small as practical. So someone will tell you that what is the size of the upper molar. And this is the upper six. And what I have done an oval. Why? Because the pre-operative IOPR said me that this is the very calcified chamber or very constricted chamber. It is not the regular, very open chamber or the wide chamber because the patient age was 55 to 60. So you need to understand, you have to be in center why you are wasting your 1 of the dentine, right? And this is the lower molar. I have like flared this part because I wanted to have entry in the mid-mesial canal, right? So this is another modification you can do, and we call it the shamrock. Luque showed that there is no need to extend full wall. For an example, if you want to go for the MB2, so what you do, you will remove this part totally. No, you just have to see the distobuccal or the distal canal orifice first, and opposite to distobuccal orifice, just use your endo Z bar and remove this portion, right? And this will result in a clover leaf appearance in the outline form. and this is we call the shamrock preparation. So I always call this, how we were doing in second year of our dentistry, especially on the models for that, I mean, inlay only and the wax pattern and inlay only, or maybe the amalgam. Yes, to be very precisely amalgam, outline form and convenience form and everything. So this is also the RCO access cavity preparation, and you should understand that this is also having a proper outline form. Because if you do not have a proper outline form, unfortunately, you will end up with some kind of mishap. Not every day, not every time. But I am here and you all are here on Monday evening at 8:30 at your enjoyment time, because you can like at least get some kind of benefit, right? So if you want to have some kind of benefit, please make sure when your file is going inside the RCO or orifice, it has to be straight. This is the very simple logic, right? And accordingly extend. So what Luke said, do the shamrock depression, right? And the most shocking thing for so many people right now, I think we will have around 100 people online, right, Shanup? So for those people, uh, this is the most shocking thing. Please do not use round burr for your RCO access cavity preparation. Vishal, are you gone nuts? No, I'm in my proper state of mind. I'm totally okay. What I'm saying, please don't use round burr once you have the drop fill. And why I'm saying this? Can you see this gouging, the lateral gouging? Yes, this is the most critical thing which ignored by many, and I wish please stop doing this because this pericervical dentist is totally irreplaceable. No human-made material, either take it from the Gerio store, even take it from the MTA, or even take it what is the best material you have in your armamentarium. No one can replace this lost dentine, and our job is to save and to not to remove more aggressively in this area, especially the dentine. And your unfortunately roundward does this every day. Can you see this? This is the gouging. So if I'm a clinician, I will just make sure I will be limited in this line, or maybe in this, or maybe in this line. You do not need to gauge this area with your round burr. So we have been taught this. They use round burr for each and everything. No, round burr is only for caries removal, and round burr is not for any endodontic purpose. When I'm saying endodontic purpose, endodontic treatment most of the time starts from the chamber, right? So once you have the drop fill, once you have a drop fill in the chamber with your TF or SF11 burr, you should use the endo Z burr, the Amazalia burr, or the non-cutting, which you call it the non-cutting burr, safe hand burr, right? But please don't use the round burr, right? And this is how I have completed this case. But I always inform the patient before, and before I start the patient, before I touch the tooth even, okay, that this tooth will not stay for a longer period of time. Cause some Batman or Superman, some superhero will put crown on top of this. Arre, bullshit. You cannot put the crown. You need to survive. You need to have some kind of conservation when you are doing RCO, right? So I have put Emacs only, but let's see. And the most important thing, can you see on your screen what has happened? Can you see on your screen what has happened? I think you all know this, but I think you all forget this when you are doing your patient. Endodontic therapy ideally has to be done in sitting position and always at the 12 o'clock. If you are not so familiar with the 12 o'clock, you can go for the 11 o'clock, but 9 o'clock position is not for any endodontic therapy. Ideally, you should have your patient in your lap and your godi, and this is how you can do your, because you will see the whole occlusal table, because I have seen greatest of the clinician doing this. Why? Because your burr, if you are a right-handed in the third quadrant, your burr, if you are sitting in a 9 o'clock or a 10 o'clock, or if you're doing in a sitting position, most of the time it will go in a more the mesial side. Dear, think about the pericervical dentine first, right? Because this is the most important thing. And what about the calcification and root canal access cavity preparation? So this was the pre-op. I will just present a case only. Okay, and how you can get the orifice, or maybe get the proper, you can have the proper RC access cavity reparation, especially the calcified tooth, right? So when you remove the caries, can you see the crystal in center? So always remember, in molars, you have to be in center. Once you see the crystal, take the ultrasonic tip, any ultrasonic tip with the water off. Please keep your water off so you will have a good vision. Once you have a good vision, try to search the distal canal first in the lower molar, palatal canal first in the upper molar, but please don't use burrs in the calcified cases. When you see a case like this, when you see a case like this, so this is how your 5 or the 7 mm depth rule will be so helpful. And this is you will achieve with your normal straight fissure burr. Once you have the outline form, you will stop, you will put your every diamond burr aside, even your carbide burr aside, and you will start using ultrasonic tape. Trust me, friends, ultrasonic tips are very routine thing in endodontics. It's not very hi-fi thing, or it's not very advanced thing. You can use your normal perio tip also. Just make sure, please don't use that perio tip after endo for your scaling, right? So keep a dedicated perio tip, keep your water off in the scaler, and start roughing this area, and you will get like this. Okay, EDTA liquid will be so helpful to differentiate between the light and the dark area for these cases, right? And this is how you can get, right? So ultrasonic and RCO, it's very vital. It's very helpful, right? Yes. And this is the full case. You can appreciate the complete healing in within the 6 months, right? And what about the MB2? Yes. So we have been taught that MB2 you will find on the mesial side in the college or in the past. In the mesial side towards mesial half of the tooth, right? And line joining from the mesiobuccal one to the palatal. Yes. You know what? Forget this definition for the MB2. And always remember, you will find MB2 in straight line of the distobuccal or the distal orifice like this, straight away at here. Unfortunately, this thing you need to achieve with your ultrasound. So this is the reason people always think that MB2 will like MB1, distobuccal and palatal will pop up and I will get the entry and I will finish the job. No, dear. You need to use your ultrasonic very precisely at the exact opposite area of the distobuccal, right? And let's see a case. So this was the pre-op. I will show you a full case protocol, okay, till the MB2. So this is the upper 6, okay, with the gingival inflammation, and patient was having severe pain. Okay, so what I did, once anesthesia is given, I have removed the tissues, the soft tissues, the inflamed tissues with the cauterization, and uh, I will remove full caries with the straight fissure burr like this, and I will do the pre-endo buildup. Can you see some kind of some kind of pulp stones are there? This is the time you should take your ultrasonic tips, right? And this is how you can get. Can you see where I have trough and where I'm getting this debris plug? It is all actually very opposite, in a straight line from the distobuccal, right? And this is how you can do. And this is how you can shape your coronal isthmus also. Can you see in the last picture the overhang of the dentin between two MB1s, between two MB, right? So MB1 and MB2, this overhang you need to remove with your ultrasonic. Always remember this, friends. Okay, and this is how you can do this. Yeah. So unfortunate thing is, as a clinician, we think that like MB, like distobuccal, like palatal, MB2 also will pop up. No, this is the area you need to trough with your ultrasonic. Remember this, friends. If you are not getting at here, my suggestion would be trough the full area from this to this point. I mean, to this to this point. And this is how sometimes I have seen MB2 at here also, because studies are saying in 70 to 80% cases you will find MB2 at the opposite of the distal orifice. But what about the rest? I mean, what about the 20-30%? There is a chance that you will get MB2 also very near to palatal canal in the center also. And this is how you can like learn. Or so this question you always think, Are endodontically treated teeth more brittle? Okay, you know what? Endodontic procedures reduce tooth stiffness by only 5%. I say 9%. I'm happy now that I was wrong because it is only 5%. I did it intentionally. Don't worry, friends. So endodontic procedures reduce tooth stiffness by only 5%. So why are you making your tooth brittle by giving crowns each and every time? Please don't go very blindly, my friends. And what about the moisture content? It is also only decreased 9% after your root canal therapy. Okay, so let me show you a live demonstration. Okay, and how you can approach the case. This is the extracted tooth, and I will use a round burr to removal of caries. This will take around 10 to 15 minutes. Okay, so I will show you two this demonstration. First is for the carriers tooth, and the other one is for the ideal access cavity reparation, right? So I will just go a little bit forward and this. Okay. Shanuf, is it visible?
Yes, sir. Yes, sir.
Okay, okay. So yeah, so this is how. Wait, I will go back. Yeah, so when you are removing caries, remember friends, you will always start from the periphery of the tooth. Please, there is nothing called affected dentine, there is nothing called infected dentine when you are doing a root canal. We should aim for the healthy, the yellow dentine. Please, that you should keep for the restorative purpose. Okay, we are not making any hollow, I mean any weakness in the tooth if you are removing. So what I believe, please remove everything. And this is how I progress, right? So always remove caries from the periphery like this. Okay, never ever approach in the center. Because what we have been like, we always want to dive inside the canal. But many times, not the many times, every time what I have seen, the case is getting failure, which has some kind of secondary caries. And why this happens? Because the first time, the first clinician was not aware, or maybe was in very hurry to remove the whole carry in doing the root canal. So please remove the caries completely first, right? Okay, and this is how, once you reach, yes, this is the outline form I'm making with the SF11 bar like this. Yes, can you see? Yeah. And this I decide according to the root pattern. Okay. So what is the shape of the RC access cavity preparation? And see, this is the depth I'm showing you right now. This is the 10 mm of the full bar, and you will go down how many mm? Only 5 mm first. Okay. So I will just go a little bit forward. Yeah, and now I'm using endo zebra. Specifically, I have used the MA zebra for this purpose. That is the endo access bar or endo zebra, right? Yeah, like this. And I will go a little bit forward. And now this is the time you will use your endo Z bar, right? To modify this wall to have a smoothen wall, right? But please don't use any burr has a active tip, which has an active tip, which can cut the floor also. We need a non-active, a safe end burr for this purpose. So you can use your carbide burr very freely, right? Yeah, can you see? I'm using it at an angle. Okay, let me show you one of the case in which we will do, yeah, in which we will do a proper endodontic access cavity preparation. What kind of access cavity preparation? The SA, as small as practical access cavity preparation, right? So this is the side determination I'm doing. Yeah, okay. Yeah, so this is how I always decide my peripheral limitation. And how, what is the peripheral limitation? You always remember this when you want to do an any RCO, your target area has to be the mesial side of the molar, like mesial half in the molar and more on the mesiobuccal cusp. Remember this, friend. I'm not saying that destroy the mesiobuccal cusp, but your all of the activities, more of the or the less you will do in mesiobuccal side. And I will determine, yeah. So this is how I make an outline form. And trust me, friend, even after 9 years of microscopic practice, 10 years of my dental practice, I still do this when I'm having a case where I need to do some kind of intentional, when we are doing some kind of periendo case or some kind of prosthetic rehab case, right? So I still do this. You can call me mad, but I still do this. Why? Because this will help me to have very limitation or maybe to have some conservative preparation in RCO access cavity preparation. So once I make the box, I will use first burr, that is the straight fissure, and how much depth I will reach the half of the burr. I will sink the half of the burr. Once I have the half of the burr, and once I have the drop fill with the TF11, I will use, yes, can you see? Yes, can you see? I have some kind of drop fill and I have some kind of, I have extended that drop or maybe that drop fill in the chamber. And now this is the time I will use my endo Z burr, my MA burr, and I will do the extension like this. So can you appreciate how beautiful it looks? And we are in the center. We have saved the most important thing, both of the marginal reach. And this is the calcification that you can remove with your endo Z or your ultrasonic tape. Okay. So this is how you can do your RCO. So I have shown you in very detail how I do. The most important thing, never ever touch your metal instruments. When I'm saying metal instruments, any kind of stainless steel or the nickel titanium, please don't touch. Always do the pre-endo first. And once you do the pre-endo, you should do the hypochlorite bath first. Once you do the hypochlorite, you will have a very clear chamber, and the most of the your complications or issues which are not getting the canal orifice will be solved very easily. Trust me, guys. First do the hypobath in any case. Whenever especially you have an a necrotic case, you should do this, right? So I will go further. Yeah, this we have covered. And yes, so that's it from my side. This is how I do. This is my practice, and this is how I do all type of works under microscope. When you know what, I always say this, especially when you want to learn RCO access cavity preparation or you want to do root canal treatment. Days are gone. Please, if you are still doing with your naked eye, at least have a good 3.5x loop. Ideally, it has to be the TTL, which we call it through the lens. Please have that TTL, right? And at least use this in your endodontic therapy because your tooth diameter is only 1.5 to 2 centimeter, and you are not sure how much centimeter sometimes you are removing. So forget about the millimeters. So if you are weakening the tooth with your treatment, unfortunately, friends, you are not doing very correctly, right? So this is my upcoming course. If you want, if you wish to attend, if you wish to have more details, you can DM me, and I am very available, and I am very approachable on this all social media platforms, right? And before I end, I would like to thank again Dr. Shanu for inviting me here and taking this webinar. For right now, I'm saying that almost 200 participants are there. That is very great number. Whenever you are, I have taken webinar for so many countries also. But let me be very honest, Shanuf, your team has done very good job. And 189 or 200 participants, if you are getting in the live webinar, that is commendable. So salute and happy endo to everyone. Uh, please, again, start using magnification if you are not doing. and have some fun.
Thank you so much, sir.
Yeah,
Okay, so shall we do a little bit of a question answer session, sir?
sure, sure, sure. Please go ahead.
Uh, okay, sir. So I would request the audience to please to post your questions relevant to the topic. So today's topic was definitely regarding about access opening. So I would request the audience please do post your questions just related to the topic. So let me select. Let me see if any questions are available.
Okay, let me read. Let me read only. One has asked endo Z and endo Z bar are different. No, sir, that both are the same bar only. Some we call it endo Z and we call it endo Z. So
Yes,
both
sir.
are, in,
Yes,
we
sir.
have some different accent in Gujarat, so we call it endo Z. You call it endo Z. Sorry. And what are the ultrasonic tips? Okay, so Woodpecker has some of the very good ultrasonic tips for this, and it is economical also. Even if you want to have a very good and the gold standard tips, then you can have the Densefly StarTex 2 tip also. StarTex 2, it comes in StarTex 1 to 5, right? So 2 is my most favorite, which you can use for your MB2 also, right? And wait, questions are pouring, Shanuf, now. I think you need to read one by one. I
Yes,
think I
sir,
will not.
I'll try to select
Ah,
the questions, sir, because there are some questions which are not relevant to the topic also.
okay.
So I think there's one question regarding about magnification. Like, if anybody is planning to purchase a microscope in their practice, what would you recommend? Which magnification has to be started
I
when
think
purchasing a
you
microscope?
can start with the normal 5-step basic microscope. Okay. And
Okay.
it's always about your budget, how much your pocket is allowing to invest. Okay, so I have three microscope. When I started my microscopic journey, I got the first Indian made, and then I got the Zoomex, and right now also having Lebomed also. So this is how you can progress, and it's always about first, whenever you wish to have a microscope, have a proper training. If you are not getting the proper training, at one point also I will say it's okay, but you need to spend more time with your patient, because it's always about the coaxial vision, the indirect vision. So my suggestion would be don't ever go straight away with the microscope. Better to go with the loops first. Have some practice in your indirect vision, indirect illumination, and then shift to the microscope. But you can have that Lebomed Prima or Zoomex as a basic microscope. Okay, we have so many companies right now in market, so it's always about you will get so many specifications also. As a clinician, I always say this: how you take taste drive in your for your car, the same way you will take taste drive for your microscope, and which suits better for you, you will get that. Because if you are a clinician and if you are going much into the specification, ultimately your job is to do the root canal treatment. So yeah, so if you are getting trapped into this that suggestions or that specifications, eventually you will come out with nothing. So better to have test drive of all of the listed microscope and then choose one.
Okay, okay, sir. So again, I'm requesting the audience because there's plenty of questions regarding about irrigation, plenty of questions regarding about retreatments. So I would request only to ask questions because I'm going to select only the questions regarding about the access preparation only. So I think there's one question regarding about is the shamrock preparation only limited to MB2?
No. Shamrock preparation is basically what you need to understand, that shamrock is like just a selective extension. Don't extend everything on that side. For an example, I have shown a case right in the presentation. So if you want to see the if you want to have MB2, just extend that particular part from the mesiobuccal one, and now try to do everything. Try to try to irrigate, try to reach the apical foramen, and try to shape the canal and fill the canal, right? So this is how you can just extend. So even this is for your radix cases also. This is also for your mid-mesial cases also. So this is not only limited to mesiobuccal 2.
Okay, sir. So how to make up if perforation occurs? What instrumentation used to give MTA at that exact location? There is one
I'm not
question regarding
understanding.
about it.
I'm
I
not
think it
understanding
is
the
regarding
question.
about the perforation repair during axis preparation, sir. If
I think we
that's
should
going to be
discuss this on later on. I think we
yes,
have
definitely, sir.
some
Definitely,
other
sir.
way. Yeah.
So I think, sir, shall we wind up the session? Because I think most of the questions is related to out of topic questions. But definitely, what we could do from our side is that since you had already shared your social media platform, so people having regarding about, having questions
Yeah,
regarding about diagnostics,
they can
they can
send me DM
definitely
on
get contact.
Instagram.
Yes, definitely, sir. Definitely, sir. So I
I have
guess.
no issue.
Yes, sir. So definitely, so I think we'll wind up this session, sir.
Yeah, okay.
So if anything is there, we'll try to, contact through social media platform. So it is actually open we have our platform. Even sir also has his platform. I would definitely recommend the audience to please, definitely follow our sir's Instagram page where you can actually appreciate his clinical works. So thank you so much, sir, for sharing your knowledge and expertise when it comes towards access opening. And surely many of us would leave this discussion with amazing takeaway points and implement techniques as per discussed. So thanks
Yeah,
to
pleasure.
all the doctors for patient listening and your participation for this webinar. And I hope all of you will depart this session with positive, confident manner. So once again, thank you so much, sir.
Pleasure. Thank you.
Okay, so it was definitely a wonderful and informative session, and we really appreciate your valuable time given for this series episode.
Yeah, thank you. Bye-bye.
Okay, sir. So to know more about our upcoming webinars and workshop, please do check out our website, which is iedpe.org, or you can follow our Instagram and the Facebook pages as well. And if anybody has missed out our previous webinars, please do check out our YouTube channel as well. And we really appreciate if you could subscribe also.
I
So
will do
thank you
that.
all, and yes, sir,
Okay. Okay.
and have a great night.
Okay. Bye-bye.